Best wishes.
Hello. Can we have the presentation on the screen? Hello everyone. So, coming from such a complex surgery, coming to simpler things, I'll talk about total hip replacement in acetabular fracture. Now, as we all know, acetabular fracture is not a single type. Lateral classified into 10 types, with each having its own variant of multiple types. So we are dealing with a number of different profiles that we get for doing a replacement. But there are only 3 stages of intervention for THR in an acetabular fracture. Either you do it acutely, that is in a fresh fracture that you feel that cannot be reconstructed properly, or the head is broken, the neck is broken, or if there is too much of marginal impaction or cartilage loss. In these conditions, you go acutely and do a THR, or in delayed THR in neglected fractures or in operated fractures. Now, AAOS classification for acetabular bone defect, we all use in revision hip cases. It was classified into 5 types, but if we just pick the first 4 types, that is the segmental deficiencies, the cavitatory deficiencies, and the combined deficiencies. These 3 parts are which we actually get in an acetabular fracture when we are operating. And the 4th is the pelvic discontinuity, that is also a type of acetabular fracture when we are operating like a transverse fracture or a ACPST type, which has not united. So this classification is commonly used. So in this multiverse of madness of acetabular fractures, I keep a few tricks up my sleeve and would like to share those. So the first is how to use this multi-hole acetabular cups. Now this is the key horse of workhorse cup of acetabular surgery, THR in acetabular surgeries. These are made up of trabecular metals. These are highly porous, made up of titanium or tantalum, and due to their porosity, they have a very good scratch fit initially, and also have quicker osseointegration properties. Now this is a case example how a multi-hole cup has been placed, and screws can be placed all over the direction in whatever area we get the bone stock. This is a case example of a comminuted posterior wall fracture with dislocation in a 49-year-old male. This is an acute fracture. As we can see, it is a 5-part posterior wall fracture. So as an astute acetabular surgeon, I fixed it. This is the post-operative X-ray, and the patient was fine. I used 2 spring plates over a recon plate. But at 8 months, the head went into avian. We got this CT scan done, and the posterior wall has united and had a good bone stock. So in these cases, we can straight away do with a multi-hole cup. It's just like a pristine acetabulum. We just press fit it and put 2 screws and 1 kickstand screw, and this is good to go. So second is the impaction bone grafting technique. This is a good case, good technique to learn for doing an acetabular surgeries. So this is actually you harvest the autologous bone graft from the femoral head, or you can get an allograft. You morselize it, make it into pieces or croutons of bone graft, then you impact it into the cavitatory defects of the acetabulum using an impactor, or you can reverse ream it. And when it forms a hard base, you can just put your cup over it. Sometimes meshes are used to reinforce it, but I personally have never used a mesh, but it is used. So you can prepare the graft using a bone mill, or you can just manual prep it using femoral head slices which have been cut using saw, bone cutters and nibblers. So we can do it with a cemented cup, the impaction bone grafting technique, such as in this case. This is an ACPST type fracture, 50 years old male, bedridden for 3 months. And on 2D sections, the columns look united. So we went ahead, did impaction bone grafting using the femoral head. This is the post-operative image, and this is 1 year follow-up. Next, we can do the same technique using uncemented cups. Such as this is another case, ACPST type fractures, 12 weeks old, neglected in a 48 years old female. Again, the columns looks uniting, but there is a central defect. So we just use the femoral head, pack it inside the acetabulum, compress it, and put a multi-hole cup. This is the intraopsy arm image. This is 1 year follow-up. The graft is united, the cup has been taken up, and patient is walking independently. Next technique is the strut bone grafting technique. Now, a strut is a rod or a bar forming a part of the framework and designed to resist compression. These are usually used for a posterior wall or a dome defect. A piece of cortical bone is cut, prepared, and placed in the cavity, fixed using an implant, and then the acetabulum is reamed and a cup is placed. So we can prepare this part using a saw to remove the cartilage from the femoral head if you are using the same head, or you can use a female acetabular reamer. This figure of 7 bone grafting technique has also been described, where the head is cut into a figure of 7, then fixed using 2 screws with the head overlying into the acetabulum. The cup is reamed and the acetabulum is reamed and the cup is placed. This technique was used in this patient, the posterior wall fracture with a femoral head in a 40-year-old male, 2 months old neglected fracture. The head was also broken and not stable. So posterior column plating was done. Then posterior wall reconstruction was done using the figure of 7 graft and screws, and then the cup was placed. This is the 3 months follow-up of the same patient. Similar technique was used in other cases also, where instead of just using the screws, we use a plate to further reinforce the graft. Another case, again using the plate and the screw to reinforce the graft. The next technique is of the trabecular metal augment technique. Now these trabecular metal are the latest in the armamentarium of revision hip surgeons. So they come in handy for the acetabular surgeries too. These are again highly porous material, almost similar to the cancellous bone structure, made up of again titanium or tantalum. They have an excellent ingrowth property, so they just osseointegrate very quickly. They have much advantage over using an allograft because compared to the allograft, they have better strength and it does not resorb over time. Also, there is no risk of disease transmission in using the trabecular metals. They comes in various shapes and sizes, such as a shim, hemispherical cup, and they can be used at multiple ways also. So this is a case, a 1-year-old posterior acetabular surgery done, 35 years old male. The CT shows the head is subluxated posterior superiorly, almost there is no posterior wall or bone stock to support the head. So we went ahead and did this surgery. This is a trabecular metal augment in flying buttress position. It was used with a trabecular metal cup. This is the 3 months follow-up. Patient had started weight bearing with a lurch, and this is the 1-year follow-up. Patient can now drive independently, walk, and half squat. Next is the acetabular cage construct. These have been present for a long time. It is again based on the principle that we impact the cavity and use this cup to reinforce the fixation, and while the graft inside the acetabulum integrates with the host bone. So these are very good for pelvic discontinuities. You can put screws in the ilium part, or you can put that ischium part into the slot created in the ischium. These are again made up of titanium with rough surfaces for integration and allows early weight bearing. This is the technique. This was taken from the internet. The acetabular cage is placed. The screws are randomly placed in maximum bone possible and covered with a bone wax. Then a cementing of the polythene liner was done. Next is the cup cage construct. This is one step ahead of the cage construct. This is more biological, as a cup was made up of titanium, but here a trabecular metal shell is initially used, which is placed in the position of maximum bone contact. Usually it is retroverted or vertical, but where it gets maximum bone contact. Then a cage is placed and fixed to the ilium and ischium in a more better position. And finally, the polythene liner is cemented over the cage in desired position of maximum stability. These are again excellent cases for non-union cases or pelvic discontinuity non-union cases. These are the 4 steps. First you ream the acetabulum, then you put the trabecular metal shell, then the cage, and then finally the liner. This is a case example taken from the internet. There are a few other techniques. I don't have personal experience of using these, such as triphalangeal cups, custom made acetabular cups by using 3D printing techniques, and the coned hemipelvis techniques. So my take-home message is, as a hip surgeon, you should know when to intervene in a acetabular fracture, when to fix and when to replace, and learn the technique of at least impaction bone grafting, wall and dome reconstruction, and the use of metal cups, and you will be able to do maximum of the cases. Thank you so much.
A big round of applause to Dr. Ashwini, because he has shown some exemplary cases. Now, we'll start. First of all, I would like to also highlight that neglected acetabular fracture is a very great topic, and I published about 65 cases, 5 years follow-up. How do we manage it using a THR? So that's published in CCOT, 5 years follow-up. That's very well examined, and flow diagram is there. How do we approach, and what are the techniques to be used? So if you read that paper, you'll have lots of idea. So until we get back to Dr. Shekhar Srivastava, I'd like to felicitate our faculties for being here. May I request Dr. Ashok sir to kindly felicitate the faculties, and we'll get back to Dr. Shekhar. Shift to OT, please. Can you shift to the OT, please? And then we'll have Professor John Moore later, once for questions are done. 2 minutes, sir. I'll call you. Can you shift to the theater, please? Yeah, we are having nail scone. It's